cancer syndrome. Let me get this going. Sorry. I have no disclosures. Our learning objectives are to review advances in genetic sequencing methodology. We're going to discuss indications for targeted testing versus panel testing. We're going to learn about common cancer susceptibility genes, review management guidelines of hereditary cancer syndromes, understand how to interpret genetic testing results, and then recognize limitations to genetic testing. So I think it's good to review the evolution of our diagnostic spectrum of DNA sequencing. So back in 1977, the wonderful Dr. Fred Sanger, he invented a method for DNA sequencing. It's now known as Sanger sequencing or first generation sequencing. And essentially, this was what contributed to the completion of the Human Genome Project between 1990 and 2001. There was a time period where, while slow, scientists all over the world contributed, and they ended up mapping out all 3.1 billion base pairs of our DNA. And in doing so, what that did for us in the world of genetics was allowed us to make large scale comparisons and actually hone in on identifying where these disease-associated genes were located in the DNA. Some people may remember the big exciting discovery of BRCA1 and BRCA2 in 1994 and 1995 when they localized those genes to chromosome 13 and 17. And that was, again, a very exciting time in medicine. Fast forward 2005, we had an upgrade in the type of sequencing, and we're able to do larger fragments of DNA at one time. It's much faster. They call this NGS or next generation sequencing. Again, another upgrade in 2007. In 2011, we had the addition of third generation sequencing coming about, so even newer technology. The differences were that, like with second generation sequencing, we were able to sequence out amino acids and look for small changes in the DNA. So I always tell people it's kind of like looking through the pages of a book. We're looking for one misspelled word, one missing word, a sentence that's kind of out of order and doesn't make sense or has an early stop to it. So that's how we identified mutations with sequencing, essentially. And 90% of all germline mutations are actually identified with that method. So third generation sequencing allowed capability for that and large rearrangement testing. So that's looking for large deletions, insertions in the DNA. So I always tell people it's kind of like looking for added or deleted chapters in that book. And that's actually where 10% of all genetic mutations are found. Now, why I bring this up is that patients who had testing prior to 2011, their testing is incomplete. So if they never had update testing, something to think about with your patient population. It's only 90% complete per se. And then we had the nano sequencer come about, and essentially now we are able to sequence out the entire genome, millions of fragments, even billions of fragments of DNA at once, and it happens very quickly. It's very accurate. Before I move on, I do want to point out two things. One is that in terms of Sanger sequencing, it is the gold standard. It remains the gold standard today. Where we use it is actually to validate our next-gen sequencing data. So we have a patient, we send their genetic test off, and it comes back positive. That lab is going to rerun it to ensure it's a true positive with Sanger method. And then the other place that we use it is whenever the patient comes in, they have a known family member, blood relative with a genetic mutation, and we're going to do single site cascade family-based testing for them. So, where we know exactly where to look in the DNA. I just want to touch on a couple historical facts that are related to multi-gene panels. The most important being Myriad Genetics. So Myriad patented the BRCA gene. That meant that they were the only lab in the US that could sequence out BRCA1 and BRCA2. So, we had the capability of testing multiple genes at one time. As you saw, the second generation sequencers were there 2005, 2007. Other labs were doing that, but why it really didn't take off and why genetics was sort of stunted in its growth is because as holding that patent and, with BRCA being 80% of all the cause of hereditary breast and ovarian cancer, you always wanted to rule that out first. Unfortunately, Myriad charged $5,000 or more for the test. Back then, insurances didn't always pay for it. In fact, more often they didn't pay for it. And if you did get them to pay for it, they wouldn't pay for a second test if it was negative. And so things were a lot more difficult. Not a lot of patients could afford to pay for that out of pocket then, let alone now. And so we've come a long way. The US Supreme Court ruled in favor of the Association of Molecular Pathology that it is illegal to patent a gene. It's naturally occurring. So that was a big deal for us in the world of genetics. And then this was immediately followed by FDA approving several sequencers. And then the NCCN, in accordance, updated their national guidelines to include that panels are indicated for individuals who tested negative for a high penetrant gene or have a family history that's suggestive of more than one syndrome. So phenotypical overlap is something that we were seeing a lot of. And essentially, this is a study, it was retrospective out of Myriad. They looked at 9,000 cases where they did genetic testing for Lynch syndrome and BRCA, which is known as hereditary breast ovarian cancer syndrome. And essentially that was a period of 7 years. What they found was that 7% of patients who tested positive for HBOC, who were tested for HBOC, met criteria for Lynch syndrome. And then the opposite, 30% of those who tested for Lynch syndrome actually met criteria for HBOC. Another study out of Ambry Genetics, and this was looking at data between 2012 and 2013. Now, Ambry was doing panel testing for a number of years at that point, and they looked at 874 patients that specifically underwent panel testing with BreastNext. And these were patients that previously had been tested at Myriad and were BRCA negative. So all of these patients had either a diagnosis of, you can see there on the left, breast cancer or ovarian cancer. And what we found was that 65 of those patients, or 7%, tested positive for another cancer susceptibility gene outside of BRCA. So I'm going to get a little close here, but you can see like 19 were CHEK2, 18 were ATM. We got PALB2 that was 15. We have TP53 lead remaining 4 of them, P10, RAD50, RAD51C, BRIP, MIR11A, NPN, just goes kind of on and on. But the point being is that, we should be, sequencing out more than one genetic syndrome at a time, essentially. I get this question a lot. What is the criteria for genetic assessment associated with breast, ovarian, uterine, pancreatic, gastric, colorectal, and prostate cancer? And so these are the red flags. They are listed on NCCN as well. I'm just going to go through them. So if you have a patient that was diagnosed with breast cancer, prostate, colorectal, or uterine, either at or before age 50, they do qualify for genetic testing. If there's a treatment indication for a PARP inhibitor because they're BRCA positive, then they're going to qualify. That's going to be your high risk HER2 negative breast cancer. It's also going to be your metastatic breast, prostate, and ovarian cancer. Certain histology also is a red flag. So basal-like phenotype, what we know is triple negative. Medullary, more than one breast primary, whether in the same breast, whether synchronous or metasynchronous. Certain other histology, invasive lobular carcinoma with a personal and or family history of a certain type of stomach cancer known as diffuse gastric. Diffuse gastric cancer is overall fairly rare, but we do see it. It's different in that it doesn't form a mass. It involves a lining of the stomach. And essentially, there are signet ring cells there, and they stain E. cadherin positive, just like invasive lobular. So it's sort of a connection there. Anyone with a pancreatic cancer diagnosis, ovarian cancer diagnosis, specifically epithelial. There are germ cell tumors, of course, that happen from ovary, but often we don't think about genetic testing for them. Male breast cancer, Ashkenazi Jewish ancestry are criteria for testing. Of course, 1 in every 40 individuals who identify with Ashkenazi ancestry carry one of 3 founder genes that are associated with BRCA. So that's why we keep that in mind. And just while we're on that topic, those are the only 3 sites that are covered on 23andMe. We get that a lot. Well, I had 23andMe. So, but there are over 3,000 sites where one of those mutations can be found. So again, that would be incomplete. One of the newer things, obviously, in the past few years is molecular tumor profiling that's suggestive of a germline mutation is another reason to do testing. And then when we look at family history, if they have a known mutation in the family, obviously, we're going to offer genetic testing. If they have greater than or equal to 1 blood relative with any of the following. So what's a close blood relative? It's first and second degree. First degree, remember, are your parents, siblings, children. Second degree are going to be your aunts, uncles, and grandparents. So family history of either breast, uterine, or colorectal before the age of 50, or any of these three are standalone: ovarian, pancreatic, or high risk for metastatic prostate cancer. And then finally, we have on this slide where if we have greater than 3 close relatives with either breast or prostate cancer at any age, then we offer testing. Next is going to be polyposis. You want to be thinking about it if patients have 10 to 19 polyps, but definitely more than 20. You want to think about genetic testing, and then individuals who have a personal and or family history of greater than or equal to 3 of the following. So because there's some overlap, just want to keep genetic testing in mind. If there's breast, pancreatic, prostate, melanoma, sarcoma, adrenocortical carcinoma, brain cancer, of course, leukemia. There's that diffuse gastric cancer again. Certain dermatologic manifestations. So we sometimes think about neurofibromas with NF1. We also think about fibrofolliculomas with Birt-Hogg-Dubé, macrocephaly, and hamartomatous tumor polyps. We're always, we're all more familiar, I think, with adenomatoous polyps, but the hamartomatous polyps are associated with P10 Cowden syndrome. Not going to spend much time here. Just know that these are common genes that you will be seeing on, your multi-gene panels whenever you do order genetic testing. But you can see that I kind of highlighted what are the high-risk genes for cancer, what are the moderate risk, and then the elevated risk. And as you can see, there's a lot of overlap. There's a lot that are associated with breast, ovarian, prostate, and pancreatic, for instance. So we'll kind of skip through there. Let's take a look at our first case. This is a patient that I met very early on in my career, I think back in 2007. She had breast cancer. She was diagnosed age 27. Unfortunately, she was diagnosed in her second trimester of pregnancy. And she had a very large tumor. You can see the features there on the right: invasive ductal, basal phenotype, medullary, 4 centimeter, and lymph node was involved. So we did offer her genetic testing. And she was confirmed to have a BRCA1 pathogenic variant. And so this is very phenotypical. Again, triple negative, medullary, early age of onset. We want to be thinking of BRCA. Excuse me. And so what are the cancer risks associated with the BRCA gene, or what we can refer to as hereditary breast ovarian cancer syndrome? Very high risk of breast cancer, more than a 70% chance that a woman will develop breast cancer if she has either one of those genes. Obviously, if she survives first breast cancer, is very high risk of getting breast cancer in the contralateral breast. Ovarian cancer risk is incredibly high, particularly with BRCA1. We see upwards of a 60% risk, and then BRCA2 upwards of a 30% risk. Prostate cancer risk, again, quite high, highest with BRCA2 upwards of 60%, and then BRCA1 upwards of 26%. We see male breast cancer risk is quite high, again, particularly with BRCA2. Same thing with pancreatic, mostly with BRCA2, and the melanoma only has the association with BRCA2. So how do we manage these people? And so as I go through management, I'm just going to say, refer back to what we talked about for BRCA, because a lot of it's going to be the same surveillance schedules. But female breast cancer, we're going to teach them how to do a self-breast exam starting at the age of 18. They're going to be plugged in with gynecology. And then eventually they're going to plug in with us in the high-risk hereditary carrier clinic, usually closer to age 25. We're going to do clinical breast exams every 6 to 12 months. We do implement breast MRI around age 25. Earlier, if there's an earlier age of onset, that's done annually. Around age 30, we start mammograms. Those, again, are done annually, and they're usually spaced 6 months apart. So they're staggered like that because we know their risk is very elevated. We want to capture a breast cancer should it develop in the interim very early on. Why age 30 for mammogram? Obviously, the breasts are really dense. Breast density starts to, go down over time. And so they're much less sensitive in one's 20s. And then there was some early data that suggested that starting routine mammogram and doing it for years over the lifespan before age 30 actually contributes to possibly an increased risk of breast cancer because of the radiation exposure from the X-ray. We talk about risk-reducing mastectomies with these women because their risk is more than 50% that they will develop breast cancer in their lifetime. And obviously, even a stage 1 breast cancer can come back metastatic, or the patient may need aggressive chemotherapy and such. You see this all the time. And so if we can prevent it, we like to. There are limitations. Obviously, we only quote that it's a 90% risk reduction, but I think it's better than that. Essentially, these folks have many options for breast reconstruction, and we really help them along. The timing is individualized. Obviously, the patient has a breast cancer diagnosis, then they're more likely to be on the end of the spectrum, like, yeah, I want to get bilateral mastectomies. And then people who aren't affected by cancer yet, some of them are on the spectrum, like, yes, now, tomorrow, sign me up. Others are like, yeah, maybe later, not right now. And then others are, I can't even fathom having that. And so then we'll focus on surveillance until the time comes. And we have these routine conversations at every visit. I did put on their risk reducing medications like tamoxifen. Tamoxifen has a 50% risk reduction of breast cancer in these individuals. So cutting that 70% risk in half to 35%. Again, it's very individualized. I reserve it for people who are definitely done with their families and are on some like IUD because it is potentially teratogenic, of course. And I also use it in people who know that they're not going to have risk reducing mastectomies or feel like they're not going to, because again, that's a long game that you're playing there, meaning that, tamoxifen taken once a day for 5 years is going to have that 50% reduction, but not right away. It's going to happen over time. Ovarian, you're going to offer, of course, they're going to be with gynecology and have their pelvic exams, but you're also going to offer transvaginal ultrasound CA-125 at least once a year. I generally do every 6 months. Particularly if they have a strong family history. You're going to obviously offer after childbearing is complete risk-reducing BSO. Technically, there is an age that you want to target, but you would target earlier if there's a family history of earlier onset. So with BRCA1, because the risk is much higher and the age of onset is much younger, we recommend BSO between 35 and 40. And for BRCA2, it's usually 40 to 45. Salpingectomy has been shown in the general population to decrease the risks of ovarian cancer. This has not yet been proven in BRCA families, but there are ongoing clinical trials. Some patients will choose to do that. We hypothesize it's because the majority of ovarian cancers do develop in the fallopian tube. And then total hysterectomy is a new indication in 2020 for only BRCA1. They did find an association between serous uterine cancer and BRCA1. So with BRCA1, I'm also a little bit, I guess, indifferent with tamoxifen. I don't really love to use it because of that new association. Prostate cancer, we're going to obviously offer them digital rectal exam. I send them to urology or PCP for that. And then PSA is going to be done every year. PSA is very sensitive, and actually it's a different level of normal. So average population, you're going to want them under 4, but folks who have these germline mutations that predispose them to prostate cancer, you want the number to be under 3. Anything greater than 3 instantly gets a urology referral and then a MRI of their prostate and such. They start that at 45. They usually have them annually. Male breast cancer. So you teach them self-breast exams. You tell them they do have breast tissue, just not very much. You have them come in the clinic for a breast exam every 6 to 12 months. You do a baseline mammogram. You can continue to do annual mammogram on men who have BRCA2. For pancreatic, there are different options, but none of them are FDA approved, meaning that none of them have been proven to find pancreatic cancer early, but you can offer MRI of pancreas. You can offer endoscopic ultrasound of the pancreas, and you can offer clinical trial. We don't really know which is best. So, a lot of people, if they have a strong family And then patients who are in that trial also have an annual CA-19-9, which we don't tend to use for surveillance, but they do have that, and if it's abnormal, that buys them an MRI. So again, they have these trial options. With BRCA1, we only offer pancreatic cancer screening if they have a family history, but with BRCA2, we now offer it as of this calendar year, regardless of their family history. For melanoma, you want to educate on signs and symptoms, ABCDEs. You want to, talk about preventative strategies. I'm not going to get into it. We all know them. You want to offer them dermatologic exam with a skilled dermatologist at least once a year, starting at the age of 18. So back to my lady, she was again 27, 24 weeks gestation, T2N1, invasive ductal, triple negative. So we managed her with 4 cycles of neoadjuvant chemotherapy with AC. She then delivered a healthy baby girl. She went on to receive another 4 cycles of adjuvant Taxotere and then had bilateral mastectomies, of course, risk reducing on the right with immediate delayed reconstruction and had a copper IUD placed. Continued to follow her over the years. Fast forward, 7 years down the road, she had a risk-reducing BSO. Her pathology was negative. Then in 2020, I talked to her about the new NCCN update with the suggestion of hysterectomy because of uterine association, and she did have that. And then this here is a tool. Everything, has its pluses and minuses, but it's called Ask to Me, or all syndrome known to men. And what's interesting is when you calculate out her risk, this is again a 34-year-old woman who has had a history of breast cancer, who's had bilateral mastectomies. It takes into account that she's had risk-reducing BSO. And essentially, her remaining lifetime risk is still over 20%, and that's, of course, up to age 85. So why is that? These people have a unique risk of primary peritoneal cancer, which, behaves like ovarian cancer, treated like ovarian cancer. Most likely it's because of the way that the ovaries are developing in utero. So as a fetus, when those cells are kind of coming together, some of them are depositing in the, lining of the abdominal cavity and then the omentum. So I think that's why that risk remains. It's not an NCCN guideline, but I still follow all of my patients that continue to come see us with a CA-125 at least once a year, teach them about signs and symptoms to be aware of. We use that 2-week rule in oncology. I think persisting more than 2 weeks, we always want to work up. Of course, we do the physical exam, review current guidelines, and then making sure they're up on their other screenings, just like anyone would in a survivorship program, and then monitoring for updates in family history. And the reason is that sometimes there may be something that's unique to that family, and I may want to individualize, a unique surveillance in that patient, just to catch things early. So some pearls with HBOC, and you can extrapolate these and use them for other genetic syndromes as well. It is inherited autosomal dominantly. So we get half of our DNA from our mom, half of our DNA from our dad. And if somebody passed us, maybe like if it's a normal copy and it's a mutated copy, then it's 50-50 for which I'm going to give my child, essentially. The age to test is adults. We test usually between ages 18 and 25. Remember, we don't start, surveillance until 25. We would only want to test earlier if there's earlier onset. We do test children for certain other genetic syndromes that impact childhood risk, or there's an indication for surveillance in childhood, but this is not one of them. GINA, Genetic Information Non-Discrimination Act. Now that was passed in 2008 by the Bush administration. It made it illegal in all US states for any employer or insurer to discriminate against someone based on their genetic makeup. And essentially that covers everything except for those individuals who have a small, business. They employ maybe less than 50 people. And it also does not cover life insurance. So, they may be denied a premium or charged a higher premium as a result. So a lot of times you want people to be, a little bit older, 18, 25, establish themselves, get a life insurance policy, and then, have their testing. But, to each their own. They have the option. We always talk to them about it. So what is CFIM protocol? This is a very important protocol that we have to follow whenever we are doing risk-reducing BSO. It stands for, let me make sure I get it, sectioning and sectioning and extensive evaluation of the fimbriated end. And so essentially, if you're having maybe a oophorectomy because of, ovarian cysts, then, the pathologist is going to make some cuts and they're going to say, yeah, no cancer. And then with this though, they're actually combing through millimeter by millimeter, looking for an occult or incidental malignancy. And the reason is their risk is so high. Obviously these women, if they found an occult ovarian cancer, then they would be managed differently in their follow-up. They would have different cancer risks for future. And so it's, they may even have treatment. So there's a lot of differences there. But, they also sample pelvic washings as well, which is different because they want to make sure that there's no malignant cells in there. So that protocol is really important. We prefer the patient to have their surgery with someone who's familiar with that protocol. Surveillance post-op, like I said on the last slide, I like to do CA 125. Reproductive options. So just want to touch on some of those. They have many options. They have like, usually we have them sit down with a fertility specialist. They may talk about pre-implantation counseling. So, maybe like, taking, essentially looking at their eggs and maybe selecting the ones that don't have the genetic mutation. When they do that, they obviously do a complete analysis of mom and dad, but they have options for in vitro fertilization. They have options for cryo, and with cryo they can actually still achieve pregnancy with the uterus in place, even if the ovaries and fallopian tubes are gone. So that's something important. They sometimes will talk to them about adoption. They may talk to them about surrogacy as well, but we do have a team that helps with that. This is really important. Most people don't know, but BRCA is in the Fanconi anemia pathway. And so that's actually an autosomal recessive disorder. So both parents have the mutations. Both parents have a BRCA2, and there's a 25% risk that each child will inherit both bad copies. Fanconi anemia is quite devastating. These people have a very short life expectancy. They're lucky if they see 20, 30 years old. They have like developmental delays. They have, physical anomalies, other anomalies of like their heart, kidneys and such, and then high risks of kidney cancer, particularly leukemia and bone marrow failure, but, all the solid tumors as well, including breast. Hormone replacement therapy post BSO, it depends on their history. Did they have breast cancer or not? If they had breast cancer, obviously we don't want to use that. But if they hadn't had a breast cancer diagnosis, then it is safe to use. And a lot of times we urge them like a short, maybe 1 year course. But if you think about it, it's only supplementing about a third of the estrogen that they would have been exposed to if their ovaries were left in place. And the gynecologists help us to decide what's best based on is the uterus there, is it not there, and such. Psychosocial factors, these people have anxiety, they have depression, they live in fear that they're going to get cancer, they're fearful that they gave this to their child, they're fearful for their future, they're fearful about what's going to happen. They are having like maybe body image issues like around the area of reconstruction and such. There's just a lot going on with those folks. And even like with the reproductive options, it might not always be covered by insurance, like as far as the fertility side of things. So obviously this is a multidisciplinary team approach that we take with most of our genetic syndromes, if not all. We educate again on signs and symptoms of cancer, and then we monitor changes in the family. Oops, wrong way. Okay, so this is a patient that was diagnosed breast cancer at 52. We see melanoma in her mother, then breast cancer in her mother, and her mother actually passed away from metastatic melanoma. So she met criteria for genetic testing, again, 2 or more relatives diagnosed after the age of 50. And she predated panel testing as well. But I wanted to point this out because it's a variant of undetermined significance. Back in this time period, pre-2010, we didn't really understand variants of undetermined significance. We thought, do we treat them as a positive? But as it turns out, we each have 500,000 or more in our DNA. And so they're very common. Often they are reclassified as benign, what we call favored polymorphisms. And so there is we don't make clinical management decisions on these. We call them not actionable, but there is a tool that we in genetics use. And it's an NIH tool where we can look up the variant and then see, is there any conflicts in the classification? So when I looked this up originally, there was no conflicts. I don't know where this is. Okay, right here. And then looked it up again. At least one lab reports that it's likely benign. Now, when a variant is reclassified, It goes through a lot of different programs. It goes through like different algorithms and different calculations, and they use like what's happening with it in another species and segregation studies and such. And then so they're 99.9999% sure that it is a harmless change in the DNA when they reclassify. That woman did actually undergo an update panel testing and was still negative. So this is a patient that had breast cancer at 39. Just so happened she had a history of melanoma ×2, early age of onset. Her daughter had melanoma at 19. She has strong family history of pancreatic cancer in her father and grandfather. And then her aunt and uncles on dad's side also melanoma. So she met criteria for genetic testing. And again, she predated that era. So we had to start with BRCA. And she was BRCA negative. But we went a step further and we found what was going on. So her breast cancer actually ended up being an incidental, sporadic, I guess you'd say, breast cancer in a family that actually has CDKN2A. So what is CDKN2A? The syndrome is called melanoma pancreatic cancer syndrome, or people also refer to it as familial atypical mole malignant melanoma. Okay, I get it. So essentially, CDKN2A encodes for two proteins, P16, P14. P16 is really the one that's associated with pancreatic and melanoma, and P14 is more melanoma. So we can see here that the pancreatic cancer risk is quite high. We're going to offer them the same surveillance that we offered BRCA families. The only difference is they start at age 40 or younger if there's earlier onset in the family. And then in terms of melanoma, we can see the risk is super high, 76% that they're going to get it in their lifetime, upwards of. And often they get multiple primaries of melanoma. And so we're doing all the education. Dermatology is actually doing a really thorough exam. They're using dermoscopy. They're using photography. They have a low threshold for biopsy. We do send them to ophthalmology because of the risk of uveal melanoma. And then this starts in childhood. That's the other key. And it's usually dermatologic exam every 3 to 6 months. This is a patient that I can see this one better. So was diagnosed with breast cancer age 25. She had a recurrence at age 27. I don't remember all the details of her history, but the take home is she did have lumpectomy and radiation to her right breast. And so she later developed a leiomyosarcoma in that spot, and then eventually metastatic disease related to her sarcoma. She was offered genetic testing. And we have a TP53 patient. So TP53 Li-Fraumeni syndrome, very rare. It's estimated maybe 1 in a couple 100,000 to 1 in 500,000. Women have 100% risk in their lifetime they're going to get at least one cancer. Men, upwards of a 73% chance in their lifetime they're going to get one cancer. Mostly we see characteristics where they get lots of cancers. Children, the key is adrenocortical cancer, rhabdomyosarcoma. And if you're seeing a breast cancer before the age of 31, you always want to think about Li-Fraumeni. The core cancers are listed there: breast cancer, adrenocortical, soft tissue, and bone sarcoma, and then brain cancer, but you can see anything. So just keep that in mind. Breast is going to be surveyed the same. They are candidates for risk-reducing mastectomies. Key is avoid therapeutic radiation. And that's why it's kind of nice to know up front their genetic status before you do send them for radiation, particularly if you think they're high risk for Li-Fraumeni syndrome. And again, we saw there where she got a secondary soft tissue sarcoma. So in terms of colorectal and gastric, you're going to do colonoscopy, EGD starting at 25, repeat every 2 to 5 years, sooner per GI findings. Other cancers, we do a comprehensive physical exam. They have that every 6 to 12 months. We do a neurologic exam. They go to dermatology. They have whole body MRI and brain MRI every year. And they have transvaginal ultrasound, CA-125. Eventually, after childbearing is complete, they go for risk-reducing total hysterectomies, annual PSA in men, and then education. This is a patient that was being treated outside for her breast cancer when she was like in her early 30s. She came to us to have a genetic evaluation, then she ended up staying with us and establishing care, and we took over her management. Unfortunately, since her breast cancer was diagnosed, she's had ovarian cancer, thyroid cancer, mesothelioma, and Castleman's. She's cancer-free right now. Her Castleman's, thankfully, was unifocal, so she only had to have surgery for that. She also was positive for TP53 leaf-remaining. Sometimes you'll see where they have like a special interpretation there. And the reason is that TP53 is actually mutated in most cancers, like 75% somatically. So remember, we're interested in germline, at least, for this topic today. But somatically, it is a driver mutation that's in a lot of cancers. So you want to be thinking, does this patient have classical leaf remaining? Yes, this one does. But in somebody who you get a TP53, you weren't expecting to find it, then you're going to think, well, do they have a lot of disease that's driving that I'm picking up on in their blood, from the shedding of those, cells? Or, you can look at the variant allele frequency. Sometimes they'll provide that. If it's closer to 50%, then you're thinking, yeah, this is probably in the germline. This is a patient that I met. She was a 40-year-old diagnosed with breast cancer. Her aunt had uterine, and then grandma had thyroid and uterine at early age of onset. So she was unique in that she did have macrocephaly, so a larger head circumference. Now for women, and I always carry my tape measure, but for women it's more than 58 centimeter, and for men it's more than 60 centimeter. She also had a goiter, and then in her chart review, she had AV malformations that she was managed, for a very long time in vascular clinic, and then of course fibrocystic breast disease. She was tested, and she tested positive for P10, hamartomatous tumor syndrome, also known as Cowden syndrome. Again, P10 has major criteria and minor criteria. I just listed what she happened to meet, but there's actually a lot of different things there, like uterine fibroids and such. So what should you know? The breast cancer risk is more than 90%. So very, very high. Remember, average woman, is 11, 12%. Thyroid cancer risk is very high, upwards of 53%. Colorectal cancer risk, about 12%. Endometrial, about 30. Kidney cancer, about 22%. And melanoma is increased as well. Breast cancer, going to manage the same as we mentioned previously. Thyroid, you're going to do thyroid ultrasounds. They start at age 7. So again, this is something you want to offer to, testing children. Colorectal cancer screening and stomach cancer screening usually starts around age 35. It's every 5 years. Sooner, again, if they find something that they need to follow up on, like GI polyps and such. Endometrial cancer, this is one because the risk is so high that we do actually offer endometrial biopsy and put people through that until they're ready to have their hysterectomy. We also monitor the lining thickness with transvaginal ultrasound. These women start that, pretty early. Prior to having their hysterectomy, they always have an endometrial biopsy done just to, make sure that they are not going into the surgery with a malignancy. Kidney cancer, renal ultrasound starts at age 40, every 1 to 2 years. You can consider a UA, and the melanoma is the same that we discussed before. This is just like saying that there's a lot of people involved in their care as well. This is a patient that I met. She came in for family-based testing. So she was unaffected with cancer at 43. Her uncle had a CHEK2 mutation. He had testing after his daughter had testing. His daughter had breast cancer at 35. She's up there and is the first cousin. She tested positive for CHEK2. So then dad had testing to know whose side it was coming from, and dad was positive. Dad happened to have CLL. Then they had some distant relative thyroid and pancreatic. Now, that pancreatic there is actually her mother's grandfather, so her great-grandfather. So she, we knew where to look at the CHEK2. So you could do single site testing, but I didn't like the pancreatic cancer, and mom, I didn't know her status. And so I ended up offering her a complete panel. Thankfully, she was only positive for CHEK2. I mean, with like the negative result, of course, the rest of the genes were negative. That, DEL 1100 is actually a founder gene. So what do we know about CHEK2? Moderate risk gene, 20-some% risk of breast cancer, one's lifetime, elevated risk prostate cancer. Those are the two big ones that you see. There might be an association between kidney and thyroid, and I do see it. And so the higher risk, prostate cancer genes, I just kind of like put at the bottom. How do we manage? Again, breast is going to be managed the same. You just don't offer these people risk-reducing mastectomies because there haven't been any thing that says that there's an improvement in overall survival. So we just survey them. In terms of prostate, kind of same thing we talked about before, remembering that PSA has a different level of normal. I kind of put the NCCN guidelines in here just to kind of define a little bit better what guideline we follow for people at elevated risk because of a germline mutation for prostate cancer. You can consider, and I do in patients who have a family history, but it's not on the guidelines, renal ultrasound and thyroid ultrasound. Oh, so back to my patient. So when I met her, she had a normal mammogram a few months earlier. She tested positive for CHEK2 in the spring. And so we started her, she had a mammogram already and it was time for breast MRI. So we went ahead and ordered one. And her breast MRI is here, and we can see this little guy here, this irregular mass here. And so she had a point of care ultrasound, and we can see that this is ugly. And then she had a biopsy, and it was invasive ductal. So she went through all of the treatment, all of the surgery. But with timing, I feel like is everything. And this is a patient that, again, was unaffected, came in for family-based testing. Her sister tested positive for ATM after having a dual primary diagnosis of ovarian and uterine. Essentially, we didn't know what came first, but in my mind, it's probably the ovarian because ATM doesn't have an elevated risk of uterine cancer. But we can see that their father had brain, lung, and pancreatic, and that their grandmother also had pancreatic. So she did undergo single-site testing because this is a clear lineage of where it's coming from. It's coming from dad's side. Wasn't worried about testing her for anything additional based on her mom's history. And so she tested positive for ATM as well. What are the cancer risks with ATM? It is a moderate risk gene. There's a high, elevated risk of breast cancer, over 20%. Ovarian cancer risk is said to be 2 to 3%. I happen to see a lot more of it in my practice. Pancreatic cancer risk is 5 to 10%, prostate cancer elevated, colorectal cancer elevated. So again, we're going to manage these people as far as breast surveillance, very similar to what we've discussed. Same thing with ovarian surveillance. You are going to offer risk-reducing BSO only if they have a family history of it, but sometimes I can talk people into taking them out. Again, it's kind of a bias. I know I don't like you to mention bias, but I feel like that's a cancer that we have pelvic ultrasound, transvaginal, and then we have the CA-125, but those tests have a lot of limitations. So it's very hard to sometimes see ovarian cancers, and you just don't want to miss it. It often doesn't produce symptoms until it's well advanced. Pancreatic, this one also got an update this calendar year in the NCCN. You offer them pancreatic surveillance regardless of family history. The prostate cancer, we're going to manage it the same. Colonoscopy, we're going to manage the same as we mentioned in the other syndromes. This is a patient that had breast cancer at 44. We have her sister with ovarian, another sister with breast, and a, what would that be? That would be grandmother, maternal grandmother with breast cancer, later age onset. Her testing was positive also for ATM. So just a little bit of different phenotypical expressions that we're seeing in families. The one family we're seeing ovarian, pancreatic. This family we're seeing breast, ovarian. This is a 30-year-old female that had ovarian cancer, sister with breast cancer, and we have a maternal great-grandmother that had breast cancer. So she underwent genetic testing. She was positive for PALB2. So PALB2, partner and localizer BRCA2, it's found upstream of BRCA2. And so when it's knocked out, not functioning, it essentially behaves like BRCA2. So you have elevated risks of, breast cancer, more than 50%, ovarian cancer, pancreatic, male breast. And essentially you manage them exactly like we mentioned with BRCA2 earlier. This is an example of the limitations of genetic testing. So you want to be aware of what you're ordering, what the lab offers and such. This is a patient that I met when she was 43 back in, I think, 2007. She had a breast cancer that was diagnosed. And then she had a little bit of distant relative, I think it was like a third degree, so a first cousin that with breast cancer. So she ended up, because of her early age of onset, having BRCA testing that was negative. Then she, got all the good stuff. because she was triple negative. And in 2017, we were able to update her genetic testing, and we used Myriad MyRisk. So why we used Myriad for her, all of those patients that had genetic testing with BRCA ahead of panel testing being available, Myriad offered free update testing for them. And so it made sense to use their company. And she was negative. It was like a 30 some odd gene panel. 2019, she developed a rib fracture, did an extensive workup. Thankfully, it was non-pathological. She has osteoporosis. A year later, I'm seeing her back, because she's following dearly. She's many years out from her diagnosis. And, she's still having pain in that rib area. So I'm like, I don't know, we'll go ahead and do a CT scan. Let's just make sure. And actually what it saw was a tumor that was later worked up and found to be a GIST. So now I'm scratching my head like, okay, what's going on? We have a breast cancer, we have a gastrointestinal stromal tumor. Let's go ahead and try another lab. Let's do a DNA RNA. RNA kind of allows us supposedly to see deeper into the intronic areas of the DNA. And we found our answer. She has NF1, or neurofibromatosis type 1. Later that year, she actually had imaging, and it showed an area that was biopsied and confirmed to be atypical ductal hyperplasia. And so she's currently on Arimidex for that, based on the IBIS study. And why we actually started her on that, we kind of like calculated her risk using like a Gale risk model and plugging in those factors. You usually don't use this if a patient has a history of breast cancer, but because hers was so long ago and ADH is a predisposition, we thought we'd calculate it and see if there'd be any benefit from endocrine therapy. And there was. She had greater than a 20% risk of a new breast cancer primary. So we continued MRI in her, although most people will stop MRI at the age of 50 for increased surveillance if they have NF1, because most people will be diagnosed before age 50. So we talked about breast cancer being elevated with NF1, just, malignant peripheral nerve sheath tumors, pheochromocytomas, gliomas, and of course NF of the skin, which sometimes I don't know if So there's a picture there of neurofibromas, and that's like classical. They're usually disfiguring, cover the body, but she didn't have that. She had, only like one. She did have the freckling in her axilla though, and that, in the groin, and freckles in those areas are actually unusual. So now I started paying attention. They'll learn something as we go. So how do we manage these people? Again, elevated breast screening, but you usually start MRI by age 50. For the GIST, we want to do CT or MRI of abdomen, usually starting from age 50 on annually. You're going to monitor for signs and symptoms of nerve sheath tumors and use an MRI as indicated. For pheo, you want to educate them on signs and symptoms. If you're developing sweating, headaches, if you're having palpitations, like those kind of things. But ultimately, they're going to have a blood pressure checked once a year. And they're also going to have metanephrine testing, catecholamine testing at least once a year. You will do it more often during pregnancy, and you'll also do it more often or ahead of any surgery. Optic glioma, this is more like early onset, so you monitor them from birth up to age 18 with an ophthalmologist eye exam, and then you plug them in with derm or plastic surgery. This is a patient. Yeah.
Chris, you have a question that popped up in the chat about this, if you're okay with answering it now.
Yeah.
Yeah. Okay. So would the NF1 be found on just a DNA evaluation on the GIST patient, or was it found because it was an RNA study?
It was found via the RNA study. Yep. Yeah, so we just got curious, like, hey, what's going on? This is unusual. And then lo and behold, and then I was like we found it with the germline genetic testing. And then I was asking her, you have any of these funny tumors? And she's like, yeah, actually, I have this thing on my back. So then we sent her to derm to confirm that it was a neurofibroma when they biopsied it. Are there any other questions in the chat? Okay, so this patient is I don't know how I'm doing on time. Okay, a little bit. This patient's how old are they? I can't see. 47-year-old who had, no, actually they're 64. So this patient was 64 years old. They had ovarian cancer at 47. Their siblings, there's some colon cancer there and two brothers, and then a mom that had ovarian cancer. So essentially, when you look at her, she has these funny changes in her skin. Again, sometimes like you can look at people and kind of be like, oh, what's going on there? But with the colon ovarian, and then these funny changes, which are sebaceous neoplasms, you want to think about Lynch syndrome, and that's what her genetic testing confirmed. They confirmed that she had MLH1 Lynch syndrome as well as a carrier status for MUT-YH, which isn't terribly uncommon. So Lynch has 5 genes that we're looking at. The high-risk genes are MLH1, MSH2, and EpCAM. And so essentially you manage folks based on, which gene they actually have. There's guidelines that are a little bit of variations in between. But very high risk colorectal cancer, very high risk endometrial, uterine, and gastric. Those are the top 4. But you can see the other cancers such as prostate, pancreas, brain, small bowel, biliary tract, and urinary bowel. Essentially colonoscopy. They're going to have frequent colonoscopies. They're going to start around age 20 to 25. You can talk about aspirin for prophylaxis, but nobody really knows the real dose. Jury's still out. Trials are ongoing. So far, we've seen it's like a really high dose that's really hard to tolerate, like 600 milligram a day. But they usually only do that for a couple of years. So I usually just tell people for now, take a baby aspirin at least, or a full dose aspirin that's like coated, something to protect your tummy. With a PPI. And then, obviously we're going to screen them as we talked with other cases about, with pelvic ultrasounds, those kind of things, eventually do total hysterectomy, BSO. Again, with the gastric, small bowel, upper EGD, you're usually going to time at the time of one of the colonoscopies that are happening every year or 2. And then the EGDs are only every 2 to 4 years. Biliary tract, urinary tract, no real screening, but I usually do a UA in folks because it's a simple test. It's cheap. If there's blood, then we can do further workup. Brain, you're monitoring neuro exam, signs and symptoms. Sebaceous neoplasms, you just send them to derm. They see them every 1 to 2 years. Pancreas, we talked about how to surveillance for that. And we talked about how to survey for prostate cancer. And this is an example of a patient that was referred because of tumor next-gen sequencing results. So essentially, they had a colon cancer at the age of 70, but they didn't really have anything much going on in the family that was cancer-wise. So they didn't meet traditional guidelines for genetic testing, but their tumor testing actually showed a likely pathogenic MUT-YH, and then it also showed this other MUT-YH that was in the germline, and then also an MSH6 in the germline. So we did send to Invitae and did some confirmatory testing, and thankfully the MUT-YH MSH6 are VUSs, and the only thing that was pathogenic was 1 copy of MUT-YH. And so I always like to look at, again, I mentioned it earlier, NIH, and look up the variants to see if there's any conflicts, if anyone else, determines them as likely benign. At least that MSH6 Lynch syndrome gene is likely benign. So really quickly, monoallelic MUT-YH, it affects 1 to 2% of us in the population. We don't do anything for it, but you are a carrier. If 2 carriers get together and have a baby, again, 25% risk each child is going to have both abnormal copies and have the autosomal recessive condition called MAP, or MUT-YH associated polyposis. That's associated with usually anywhere from 10 to 100 polyps. It's also associated with a high risk of colorectal cancer if the polyps are left untreated. Obviously, we try to get those polyps out with colonoscopy done frequently before they develop into cancer. And in terms of other things that they're at risk for, so gastric polyps, gastric cancer, duodenal polyps, and duodenal cancer. So EGDs are important as well. And then they want to visualize the ampulla of Bader. I just put down here, in terms of how often we do that, GI really helps us to figure it out, but there is a guideline, and it's this like Spiegelman score, and it's based on like how many polyps essentially there are. It determines how, when the sequencing is for their next EGD. So this patient came to me, they had, I actually saw one of these this morning, but they had colon polyps, a little over 100. Their brother had over 100 colon polyps, and then they have mom and maternal uncle with colon cancer. And so those are not normal. That is like complete carpeting of the colon with polyps, and it's really hard to follow that with colonoscopy. So that is classical FAP, or familial adenomatosis polyposis. There's also attenuated. It's basically the same gene associated with APC gene. It's autosomal dominant. With FAP, it's 100% chance they're going to get cancer of their GI if they're not scoped regularly. And at some point, they do have to have complete colectomy and usually proctectomy. And it just really depends on when that complete carpeting happens. It's a really difficult discussion to have with patients, certainly. These folks have elevated risk for desmoid tumors. So desmoid tumors are actually really rare. So if you see them, you always want to think about FAP and offer colonoscopy and such. They have high risk for thyroid cancer, children, hepatoblastoma, and then, of course, CNS cancers. Almost done. This is a patient that was hospitalized and I was consulted post-mortem. So she was a 56-year-old female. She was admitted, in March. She had an AKI, hypercalcemia, large renal mass was found. It was IR got biopsied, and that showed clear cell carcinoma. She was very sick. She went to sniff. She got one cycle of ipi-nivo, and then a couple weeks later, unfortunately, she passed away. The only thing I could find in her chart was that she had a mother that may have had a cancer diagnosis. So she underwent Caris molecular tumor profiling because they were trying to see, like, is there any targets for her? And it was found that she had a BRCA2 mutation. Now, the key here, I feel like I cut it off. Let me see. Oh, there it is. The key here is this, the variant allele frequency. So the variant allele frequency, and that is a pathogenic alteration that we're looking at. If the variant allele frequency is approaching 50%, you do want to think that it may be present in the germline. And then you also, though, she had a lot of disease. And so that could be being shed and be somatic as well. But since we don't know and we weren't able to do any confirmation germline testing with another lab, that does that type of tumor profiling, molecular genetic testing. We just had to talk to her family and just let them know that, this is what popped up and there's a chance it could be something that's familial and that they should consider genetic testing. This is a patient that had breast cancer, 34, mom had breast cancer. It was both had invasive lobular, and then there's some distant relatives with breast and stomach cancer. And she tested positive for CDH1, which is hereditary diffuse gastric cancer syndrome. This is a pretty devastating syndrome too. It's very high risk for that diffuse gastric cancer that's really hard to detect. Because it's in the lining of the stomach and doesn't present with a mass or a polyp. Females have high risk of invasive lobular breast cancer, and there's potentially elevated risk of colorectal cancer of the signet ring type. Our GI team helps us to kind of do this like gastric mapping where they're taking random samples from the stomach and just sending them away to look for anything that may be malignant. A lot of times these people may have gastrectomy as young as 18 years old. We had an 18-year-old that had went to NIH and had his surgery. And essentially he did have early stage 1 diffuse gastric cancer at the time, despite the fact that his mapping was negative like a month earlier. And so his mapping and his endoscope. Breast cancer, we're going to screen the same, offer risk reducing mastectomies, and then colonoscopy, of course. And last slide, this is just so folks know, polyposis is unfortunately becoming more common. So there is a guideline for colonic polyposis of undetermined etiology. And there's a guideline for how we follow those patients. But I think that, the take home is you want to rule out a genetic syndrome through testing first. And I will take questions.
I don't have a question, but I just want to say that your knowledge of all of this is just incredibly impressive.
Thank you. It's a little over 18 years doing this. But I appreciate that. I learn from the patients, and I think that we really enjoy learning. Sam and I go to a conference just about every year. A lot of times Amanda Moran is with us. And so we really try to stay current with everything that's happening. I'm hopeful that Sam will give some talk at some point about other rare syndromes too that we encounter.
Any other questions or comments?
Well, thank you guys. Have a wonderful day.
Yeah, thank you all. This recording will be posted on for you all to review and listen to later too if you'd like it. So thanks so much, Kristen, and thank you everybody. Have a good evening.
Morgan,
Oh,
yes,
yes, Morgan.
we'll send them out. Yes.
Yeah, tomorrow you guys will get an email.
Now I just got to figure out how to pop off of here. There's an X.
Yeah, you can leave. Bye. Thank you, Kristen.
You're welcome.
Morgan, I think you might still be recording. I think it might have started. You're not.